Good evening to all. I am Ajay Pachuri here to present my final project about diabetic case study. Coming to the introduction, healthcare data includes information from electronic health records. Electronic health records is a source where the patient's information is entered from the start date to the till discharge with the medication and every lab entry is included in the electronic health records for future medical literatures. Implementing large-scale data analysis will offer anticipated outcomes for understanding trends and to improve healthcare and life expectancy. Unstructured diabetic data from the healthcare professionals and other areas must be familiarized and converted to nominal values with the potential solutions. In United States, diabetic as well as cardiovascular diseases are two of the most common forms of chronic illness that ultimately results in mortality. Around 9% of the population have been identified having diabetics in the year 2015, while another 3% are remain unidentified. In addition, there is a link between diabetic and cardiovascular diseases. 65 or older patients have 68% increased risk of dying from heart diseases, apart from diabetics. These are the four problem statement questions which are addressed in my research project. This is the literature survey. Coming to the data is extracted from the Kaggle website. It's originally sourced from the National Institute of Diabetic and Kidney and Digestive Diseases. The lab tests were included in the data sets with the different variables, so some of them are independent and only one target dependent variable. Here is the website for my data set. Coming to the features such as pregnancy, glucose, blood pressure, skin thickness, insulin, body mass index, diabetic pedigree function, age, and outcomes. There were no null values present in the dataset. Research design. A machine learning model is unable to comprehend the units that the features values are represented in. It treats the input as if it were only a number, but it is unable to comprehend the significance on the values being provided. As a result of scaling the data is something that must be done. As the data of pregnancy, insulin level, diabetic pedigree functions, and age exhibited in a right-skewed distribution, these factors were normalized. The dataset was split into two training and a validation sets. 75 by 20 split between the train and the test was achieved through the use of downsampling method. The data analysis makes use of Tableau and Python to create a visualization and for both analysis and modeling perspective. ANOVA analysis is used to rank features based on their importance where value with highest value of ANOVA are selected. Skin thickness and blood pressure are dropped based on the ANOVA scores. SMOTI is used to correct imbalance to prevent oversampling. Feature selections. During validation, model were evaluated based on how well they predicted in testing datasets class labels using testing dataset attributes. Evaluation is used to test set features. The best performing model was implemented. The data are associated with healthcare industry and there are 768 observations with 9 variables. The variable of interest is the outcome. The well-descriptive analysis indicates the variable glucose, blood pressure, skin thickness, insulin as well as body mass index all have minimum values of 0, which is illogical. The pregnancy column, the lowest possible month of pregnancy is 0, while a significant difference from the highest possible month of pregnancy, which is 17. That does not make any logical sense. Scaling the data will be beneficial for predictive modeling since the variability among the many predictors variables increase with the increasing scale. Mean values for diabetic and non-diabetic patients. Diabetics has average glucose levels of 141.26 compared to non-diabetic. Blood pressure, skin thickness are identical in diabetic and non-diabetic. Body mass index values are 35.14 for diabetic cases and 30.30 for non-diabetic cases. Other characteristics may need further examination to establish their connection to the target variables. Coming to the second one, distribution of glucose, skin thickness, pregnancies, and blood pressure. Pregnancies, insulin, diabetic pedigree and functions, and age have skewed samples. Blood pressure and skin thickness have bimodal charts. A tiny peak at 0 in the graph causes this. This analysis assumes bimodal distribution. Coming to the third one, diabetic diagnostic outcomes. Color shows the details about outcome. The dataset has 2 to 1 non-diabetic to diabetic imbalance. Predictions will favor the absence of diabetes. This bias will also be evident that the visualization making data inference harder. Coming to the figure 4, features by outcome. Is there is no range of diabetic risk. The range of pregnancies from 7 to 9 shows the trend of higher diabetic and non-diabetic for the first kid. However, this is a referred by earlier data. Diabetes is most common between 21 and 50. Diabetes diagnoses have been falling for decades. Younger women have higher diabetic risk than older women. Diabetic cases peaks between 24 and 42. Diabetic is rare across all skin thickness levels. And despite the number of pregnancies, women has her blood pressure varies between 63.25 to 77.89, which is a healthy range. A healthy young individual blood pressure should be in and around 90 by 60 to 120 by 80. Despite having normal blood pressure, the glucose levels above 100 to 130 milligrams per deciliters. Here is the problem to what there is a relationship between insulin levels and age groups. The chart above shows the average insulin levels across all age groups, which is within the normal range of 16 to 166 for 2 hours serum insulin. Individuals over 60 demonstrate 0.1 units per drop in normal insulin at the therapy range. What is the average BMI, average blood pressure, and average insulin for outcomes? For each outcome, 0 is non-diabetic and 1 is diabetic. Diabetic patients with average blood pressure, insulin body mass index of 70.8, 100.34, and 35.143 kg per meter square. In the above mentioned dimensions, persons without diabetic have a less significant amount. Problem 4. The study outcomes needs to be visualized in outcomes either in the form of 0 or 1. 1 stands for yes and 0 stands for no. Sorry. More individuals are diagnosed without diabetic compared to those who have. Conclusion. The glucose group have very low incidence of diabetic. Insulin data distribution shows the many diabetic cases with a 0 value, probably due to lack of data on this woman. Diabetes is more likely for body mass index values between 20 and 45 kilograms per meter square. Diabetic pedigree function statistics also shows the widespread of diabetes 0.1 by 100 to 1.25 by 100 is a common range of diabetic. Very few researchers have utilized that diabetes patients care control satisfaction, contrast categorization prediction. XGB classifiers and light GBMC classifiers are combined in this work. We showed that XGB classifiers algorithms may be used to manage diabetic patients' health. Future work. The results of the experiment shows that the machine learning models perform well diagnosing the above mentioned diabetic in patients. Such as models may be implemented in the real world as a web-based tool that include the survey questionings that is used to gauge the degree to which servers display certain characteristics. As a part of continuous research, one may also look at the values that variables found in electronic health records in order to create a more accurate model. Here are my references for the project, and I'll finally conclude. Thank you.